Now, we talked about the FDA and some medications in general. Now we're going to talk about them a little bit more in detail according to their kind of their specific names. Antipsychotics. Antipsychotics are called antipsychotics because they're used in psychosis. In bipolar disorder, they're used as mood stabilizers. This is where it's all confusing, especially for parents. A mood stabilizer stabilizes your mood. An antipsychotic is a mood stabilizer, but we don't call it a mood stabilizer. Mood stabilizers are actually seizure medication. Complicated, right? So we're going to say this all over again. Antipsychotics are medications that were originally made for psychosis, auditory, visual, hallucinations. And by the way, hallucinations can affect all your senses, right? So any sense, you can hallucinate. You can be. It's not being in touch with reality situation. Delusions. Delusions are a fixed thought, right, that is not real. The FBI chasing me. You have to be careful with delusions, because if delusions are sometimes not delusions, maybe it is reality, right? So maybe the kids do look at them in a really bad way, because maybe they behave in a really bad way all the time. And I say behavior like disruptive behavior, and so their perception of everyone looking at them in a bad way is true. So it's not paranoia. And sometimes it is paranoia. It's not true. So in kids, again, we go back to we need everyone else to kind of observe and give us the feedback. You can't only ask the child, you can't only ask the parent. So going back to antipsychotics. You don't have to be psychotic to use antipsychotics in bipolar disorder or in mood disorders. It helps stabilize the mood. And from the list that we had before, the FDA approves a lot of the antipsychotics as treatment for acute phase. In other words, a whole bunch of aggression, they're cycling ups and downs, suicidal. 1/4 of individuals that have an acute episode of, in bipolar disorder, of depressed episode or manic episode, attempt suicide. So the suicidality or suicidal ideation is very high. Yes?
I know there's different, I guess, ways you can see about bipolarism. What would be kind of, I guess, the main kind of key to look for?
Yeah, I'm sorry, I didn't hear that last part.
What would be a main key or something to look for to actually say a kid or whoever is actually going to be diagnosed with bipolar? I know there's different ways you can tell about ups and downs, but what is like a key thing to look at?
I would say two things. One is their behavior is different than their baseline, right? I mean, we're talking about something's going wrong, right? Before we can even say what it is. So key things is a very, very, very big change or a noticeable change in their moods from their baseline functioning. Okay. And the other part is anytime someone puts together suicidal ideation with changes in levels of aggression or irritability, that's another part that I would definitely look into as bipolar. Okay. Doesn't mean they're bipolar, but it kind of, like you say, what are we going to look for and what really makes, the red flag go up? Okay. And then from there, everything else we've talked about, because none of these conditions are one thing. They're a whole bunch of symptoms. So we were talking about the antipsychotics. We have the older generation antipsychotics and the newer generation antipsychotics. The newer generations are the ones we talked about. Now we have Abilify, we have Geodon. Every single one of these antipsychotics have different, even though they have some basic potential side effects, they all have their own characteristics, okay? Some are sedating medications like olanzapine and Risperdal, right? Some do not cause as much sedation, such as Geodon and Abilify. Some have significant increase in appetite, like olanzapine and Risperdal. Some don't as much, but potentially can, like Geodon and Abilify. Okay. Seroquel is kind of in the middle with the appetite, causes a lot of sedation. A lot of different reasons why we use these medications. Sometimes we need them for their side effects as well. We want them as a mood stabilizer, but we need them to help them sleep at night. So we use the ones that cause more sedation at the beginning. Risperdal, for example. Seroquel is another one. If they have significant sleep problems, maybe Abilify is not the one to use. If there's issues with obesity and weight, maybe Abilify. There's tons of considerations. Okay. So if there is an issue with safety, then we have in our minds which ones we need to use quickly. Okay. None of these medications, if a child is thinking about suicide, work and keep them safe fast enough. That's why we need inpatient treatment. This is very important. This is something everyone should take away, right? Whether it's bipolar or not. If there's a safety issue, right, and you're not going to be able to keep your child safe, that even includes little guys that are 5 years old that can run through traffic because they're going to do it if they want to, whether it's 3 o'clock in the morning or not, then you really need to consider the inpatient. That's when we do the inpatient stabilization and we treat the acute phase. We have mood stabilizers. Really, none of these mood stabilizers work. You can be used in acute phase, but they don't work fast enough, right? So the antipsychotics, you might see the results in less than 24 hours. We're not talking complete results. We're talking calming down, right? Maybe safer, less aggressive. Mood stabilizers, this is kind of my explanation of mood stabilizers. For neurologists, they use them as seizure medications. Psychiatrists use them as mood stabilizers, okay? Except for lithium. Lithium is not used in seizures. But Depakote, Trileptal, Tegretol, carbamazepine is Tegretol, Lamictal, all these are seizure medications. Now, we say, okay, well, we can use them because we all have this, most of us, I guess, have the concept that some medications are used for one thing, but they can be used for others. But when you say this to a parent and they go home and someone else says, why do they have them on a seizure medication? This is wrong, right? Then the parent feels very uncomfortable and they need to understand that it is a seizure medication and someone else might tell them that. Antipsychotic, they go home and they tell, the mom that's brought the child in goes to the house and goes, this is an antipsychotic. The word psychotic is in the movies, right? No one wants to be on an antipsychotic because it means you're psychotic. You're crazy. Teenagers feel this. They're not crazy, right? But they feel like they're on these medications, they must be crazy because they see it on TV and this is what crazy people are given, right? So psychoeducation, and we'll get to that, is very, very important. Okay. This is very important because parents always ask, well, how long are they going to be on this medication? They're doing okay. They've been okay for a week. Can I take them off of it? Please, 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 please. No, you can't. Because we need the maintenance therapy. The maintenance therapy is to decrease the possibility of the recurrence of the symptoms, but it's also to give the therapist time to work on the coping skills, right? While the patient is stable, so they can work on, if you're trying to work on anxiety issues and you're having panic attacks in the office with the therapist, what are you going to work on? Nothing, right? If you're psychotic and you're in the therapist's office, what are you going to work on? Nothing. So you have to have a level of stability, emotional stability, to actually be able to do some work in therapy. So that's what medication does also. It permits you to work in therapy so that you acquire the coping skills, right? The resilience to be able to deal with your symptoms as time goes on. So 12 to 24 months, 1 year to 2 years is what's recommended. 80 to 90% of individuals relapse, whether they're on medication or not. That being said, the good thing is it's very different when you relapse and you start having trouble with sleep and you get somewhat irritable and you're having some racing thoughts and you go to the psychiatrist and you say, symptoms are coming up again. I need to do something about it. They get back on their medication and you cut there, right? As opposed to not seeing symptoms in your teenager until they've stolen the car 3 times, they're back on the drugs, and she's gone pregnant. Right? Because she's hypersexual. So if you can catch the symptoms, the relapse can be much less intense than if you just let it go by. Okay? That's why therapy is very important, because you have to have some self-awareness to be able to say, whoa, something's going on. And when you hear individuals that have bipolar disorder that are successful, they can be very successful, high-functioning, very creative individuals, but they know when they can go out there, right, and expose themselves, and when they can't because their symptoms are starting to present, right? In other words, when they start getting irritable or they're starting to get depressed, they don't go out there in public. So this is why a lot of the individuals that are very famous individuals that have bipolar disorder, we don't know that they are until something really bad happens, and then we go, oh, I knew it, they were bipolar disorder, right? Well, you didn't know. Okay, baseline and follow-up care. You're going to see tons of different ways of following up, right? If you start someone on medication, they should be seen within 2 weeks, right? If you start a child on medication, they should be seen within 2 weeks. If you can't see them within 2 weeks, they should be seen within 2 weeks. I mean, that's just the bottom line. Because what you want to make sure is that they're not having side effects that you're not catching. And parents can't always catch every single side effect. And it's interesting, but kids sometimes tell their psychiatrist more than they tell their parents, right? Because they don't know us well enough that we're naggers also, right? So they don't have that, oh, she's nagging me kind of thing, right? If I have a headache, if I ask 100 questions, they'll roll their eyes, but they'll answer them. If their mom tries to ask those 100 questions that afternoon, oh my God, you know, and they have to, again. So it's a different kind of relationship there. So yes, they have to be seen within the first 2 weeks after starting a new medication. Okay. Then you start, as you see the parents and the child developing, and you know that they know more about their meds, they're able to describe their symptoms better, then the follow-ups can be spread out further, okay? There are some individuals that do not like to come into the office, and coming to the office generates tons of anxiety and anger and, oh my God, I don't want anyone to see me going into that building, and of course they bump into their friend or someone in their classroom, and it's just, you know, it's embarrassing sometimes, right? Because we still have this stigma. So, you know, we have to consider all those things as well. To be able to, the main thing is that we don't want to lose our patient, right? Because we want to be able to keep on offering the help that we need to, that we feel they would benefit from, right? So adjustments need to be made, especially in teenagers, especially in teenagers. Okay, so I've got 3 minutes to go over this one. Psychoeducation, we already talked about. Family therapy, why? Because when you have bipolar disorder and you're angry and you have a whole bunch of relationship problems and you treat people badly, they don't like you, okay? And so they're not really interested in doing a lot for you, even if they are your parents and they love you. I love them, but I can't stand them. I love them, but I don't like it when they call me a B, right? I'm not even going to wake them up in the morning because it's this fight all the time, truancy charges. Right? So once you get into family therapy and kind of educate the family and also help them on, you know, help the child kind of realize how they're affecting their family and the parental response on how that affects the family, it really decreases a lot of the stressors. Interpersonal therapy is for the person to realize how they're getting along with everyone and also to help them with coping skills on how to get along with other individuals, how they affect other people, right? That in itself for kids and adolescents is a difficult concept, right? Because is there anyone else besides you? No, you know, yourself? It doesn't exist. So that's what has to be worked on even more so. And psychoeducational is what we talked about, medications, knowing the condition, being able to know what's normal and what's not normal. A lot of kids don't tell you that they've been hearing voices. How are they supposed to know? When were they taught in kindergarten that you're not supposed to be hearing voices? They don't know that. So they hear them and it's a chronic thing. It comes back and forth, but for them it's normal. It's been happening all their lives, so how are they supposed to know? Their mom has bipolar disorder. Their dad has a mood disorder and drinks alcohol. I thought everyone's mood went up and down all the time. How am I supposed to know that's not normal and I should say something about it? Okay. So the targets are what we mentioned. We want to do this so the person is more resilient, so they know about their illness. It prevents relapse, or it makes you have the ability to intervene more quickly. It affects School, right? Academics. The school being involved as well and knowing that the child is having these issues, it's very important. Now, some people don't feel comfortable with going out there and telling the school that they have bipolar disorder. Well, because it depends on how receptive the school is. And when we talk about the school, we're talking about the principal, the vice principal, the teachers, the therapists, the counselors. There has to be some sort of therapeutic relationship, even if you're the principal, for the individuals to feel comfortable in telling you a thing like that. That's not an easy thing to just come forth and say, yeah, I've got bipolar disorder and I'm on Risperdal and Depakote. Okay? And you might see me freak out in class. Oh, don't worry, that's just my bipolar. Right? It doesn't work like that. But kids are in school for a long period of time during most of the year, so it's important that the school understands so they can work with them, because they're not bad kids. Right? And community consultation. Okay, my spiel on aggression. If you're a teenager, it doesn't matter what you have, you cannot hit anyone, right? Because it doesn't matter what you have, you're going to go to juvie. And then if you're 16 or older, you don't necessarily go to juvie. It depends on what you do to the individual. You might go to Bexar County, right? So the bottom line is you cannot hit anyone. If you're feeling so angry, then we need to come up with another coping skill, right? So I do tell parents to call the police, right? If you're a young individual and that concept of physical aggression is not something that's really understood, and the consequences are not really there because I'm going to call the police, I'm going to call the police, I'm going to call the police, and the police never gets called, so therefore I can still hit, it's never going to be called. I always say, call the police, right? And I also tell the parents, if you see that things are ramping up, you need to go to your police station when you're not with your child and establish a relationship with the police officers there. And you say, this is the situation. When you do call the police, because you don't necessarily call 911, you can call the police station, they know what's going on, and they don't feel like, oh, there it is again. You know, this mom that just does not know how to discipline her child and is doing a bad job, and then they go there and then they say, just spank them, right? Slap them, spank them, that'll get them in line. They actually will work with you and understand what the situation is and give them the either pep talk or the whatever they need to do. Okay? Or even feel better about putting them in the car and bringing them to the hospital to get evaluated. So the legal system can actually work with you and not necessarily against you. It's easier for the probation officer to do spot drug tests than for a parent to ask their kid to pee in the cup. They're not going to do it. They'll get their brother to do it. They'll put water in. I mean, they'll do a whole bunch of things, right? So I think it is very important to get the legal system involved.